I think it's really important to identify that if we're going to make progress in terms of improving outcomes after allogeneic transplant for AML, we've already seen a very substantial reduction in transplant-related mortality and transplant complications. There's no doubt further work that can be done in terms of GVHD prophylaxis, and the data that's been presented at this meeting and I know will be presented at ASH using post-transplant cyclophosphamide in the setting of well-matched unrelated donors is actually very promising. But the main area where we're going to move things forward for patients is by reducing the risk of relapse. And conceptually, there are three strategies that need pursuing. The first is to actually ask, given the fact that pre-transplant MRD status is a predictor of relapse risk, can you do anything about that? In the NCRI trial COSI, we are randomizing patients who are deemed allomandatory, have an identified donor, but for whom there will be a delay before transplant, as is actually quite common in about 60 or 70% of patients having an unrelated donor transplant and are having bridging chemotherapy. We're randomizing them to intermediate dose Ara-C or CPX-351 Vyxeos. So that's actually going to be one of the first studies actually asking if you do something differently before the transplant, can it impact immediately pre-transplant MRD and post-transplant survival? The second question is to continue the theme of trying to identify the optimal preparative regimen and conditioning regimen. So in the COSI study, we're going to be comparing FB4, which is now pretty much a standard conditioning, myeloablative conditioning regimen for people under 55, with the new promising thiotepar-based regimen, TBF. And then finally, we're already recruiting to an important study asking if you give post-transplant maintenance with oral azacitidine, a drug called CC486, which has already been shown to be a promising maintenance agent. And in a recent study, it's going to be reported again at ASH, shown to improve overall survival in adults with AML who are in CR after intensive chemo but don't go to transplant. We're using this drug as maintenance post-transplant. It's a randomized study, Amadeus, of 320 patients, placebo-controlled, and we're already recruiting to that study. So we hope that those three questions will begin to address them, and that will be done through the Impact Network, with importantly some really strong linked translational science being led by Parashvas and Ranjan Chakravarti about the biology of the GVL effect, and also looking at mechanisms of disease relapse post-transplant.